Thank you, everyone, for joining us again for today's session. Today, we'll be talking about delirium. It's a very common symptom that we come across, but a symptom that we don't pay much attention, I must say. Many of you might have dealt with or at least seen patients with delirium, especially in ICU settings and sometimes in terminally ill patients. And the way we deal with delirium is something that we need to maybe rethink or reconsider many a times, because it's very common sight that patients being tied to hospital beds when they start pulling out lines, or then when they are being very delirious. Sometimes the medications used needs kind of modifications, or again reflection on how we deal with delirium in a medical scenario. I recently had a personal experience of my own uncle who was struggling with the end stage illness, was admitted to a hospital because of uncontrolled seizures. But here he became delirious when he was hospitalized, and he was tied to the hospital bed for a day. And that was the moment we decided that only for palliative. That's the moment the family decided to agree with palliative care, because that's something which was totally unacceptable for all of us. So it is not just a single incident. I think many of us have seen patients tied up to hospital beds because of delirium, because they pull out lines, because they pull out oxygen masks. So yeah, so that is a very important symptom, and we see it very, very commonly when people are dying, when people are in the terminal stage, when people have advanced illness. So that becomes a very common symptom in palliative care. So today we have Dr. Sanghamitra. We have heard from her once during the medical ethics session. So I'm sure all of you are familiar with Dr. Sanghamitra. She's leading the palliative care services in Assam. Welcome, Dr. Sanghamitra. Hope you are well, because during the last session you were just I think just got COVID, diagnosed with COVID, and you had to leave. Yeah, hope you are all well now. Thank you for coming today.
Thank you, Sridevi. I'm very fine, except for we are having a lot of rains here. Interesting, so much of cold in Guwahati. I really don't know why. And today, unfortunately, I don't know whether you're having a breakup of my breakup of my voice or not, but we're having quite an unstable kind of an internet connection. So please pardon me and remind me if I'm not audible. So I would like to share my screen, not wasting time anymore. Okay. Can I share my screen, Shripriya?
Yeah. Yes, ma'am. Access is already there.
Okay. Can you see my screen?
Yes.
So just in case, I'm just switching off my video so that I have some little bit of. Okay, so we're going to talk about delirium today, and it's a very important sign, important symptom of in palliative care, and we often come across patients with delirium, and that is why it is important that we all are well versed, and we have that much of knowledge to at least recognize it and treat it. So we're going to discuss about what exactly is delirium, why does it happen, what are its causes, and how to manage. So the important thing here is, trying to recognize what is delirium, so that we are better equipped to manage it. So you see, the word delirium comes from two Latin words. One is called delirare, and that's meant to be crazy, and another word called delira, or to leave the furrows. As you can see in this picture, this man is actually using a horse cart, or what to say, he's furrowing his field. So once he goes out of the track that he is actually trying to do, or trying to plow his field, that generally causes a disruption in the plowing mechanism, or so that is what it means to go out of to leave the furrow, then go towards somewhere else. So that is what is meant by delirium. There are early descriptions of delirium where Hippocrates himself had said that the patients, they move the face, hunt in the empty air, plucked naps from the bedclothes, and all these signs are bad. In fact, they Celsus also pointed out that sick people that lose their judgment and talk incoherently. When the violence of the fit is abated, the judgment presently returns. So these are the early descriptions of delirium, quite early as 400 BCE. So there are a lot of synonyms that we use for delirium. For example, acute confusion, organic brain syndrome, encephalopathy also, sometimes terminal agitation, terminal restlessness, and so on. But then, unfortunately, it is often mistaken for depression, anxiety, or dementia. So that is where our skills would need to be applied, where we need to differentiate between what is depression, what is anxiety, what is psychosomatic disorders, and dementia. So here, one term that I would like to point out is about terminal agitation, which is actually a symptom or sign, and agitation may occur in the last days or hours of life, and that may be caused by delirium, pain, anxiety, dyspnea, etc. So delirium is a cause of terminal agitation. So the DSM-5 criteria for diagnosing delirium, there is a disturbance of consciousness affecting the attention and awareness, developed over a short period of time, usually hours to a few days, and that represents a change from the baseline attention and awareness, and it tends to fluctuate in severity during the whole course of the day. So there is a kind of increase and decrease in severity. And an additional disturbance in cognition is also seen. And fourthly and importantly, the disturbance in the first and the second criteria are not better explained by any other pre-existing established or evolving neurocognitive disorder. And finally, it is also caused by physiologic consequence of another general medical condition. So this is the DSM-5 criteria to diagnose delirium. There are generally three subtypes of delirium. We come across something called the hyperactive delirium, where you can see the patient being confused, agitated, he has hallucinations, and also myoclonic. And the other extremity is called hypoactive, where the patient is confused, of course, but then he has somnolence, it seems to be withdrawn, and this particular subtype is very, very less likely to be diagnosed. Interestingly, there is a mix of both, which is quite common. And all these clinical features are actually, they fluctuate between the hyperactive and the hypoactive ones. So if we have to now differentiate between what is dementia, what is depression, and delirium. This is the main thing that we always need to be careful about, because we will not be able to treat delirium unless and until we know the differences between these three things. So as you can see, I have actually highlighted the features of delirium in red. So the onset is acute in delirium, whereas in dementia and depression, it is insidious. In depression can be acute also from, starting from few weeks to months. The course of illness in delirium is quite fluctuating, as we saw in the last slide. Whereas in dementia, it is progressive. In depression, it may be chronic. It may start acutely and may proceed towards a chronic state. The duration of delirium is, it's there for hours to weeks, whereas in dementia, it is progressive. It is months to years, and here also it is in depression also it's months to years. Consciousness is always altered in delirium, whereas in dementia and depression, it's usually actually clear. There is impaired attention, and there are increased or decreased psychomotor changes. Usually, delirium is always reversible, whereas in dementia, it is irreversible. The psychomotor changes are often normal. Attention is also normal, except for that seen in severe dementia. Whereas in depression, attention may be decreased in depression. There may be slowing down of the psychomotor changes, usually in severe cases, and reversibility is also usually seen in depression. So these are the features that will generally help us in diagnosing delirium or segregating delirium from dementia and depression. Interestingly, you see people dying with dementia, they show agitation in 87% of patients, and 83% of these patients show confusion. So that is where we perhaps we will need to find out the main cause of delirium. So why should we identify and treat delirium? It is common. Almost 10 to 25% of all hospitalized patients show delirium. Elderly hospitalized patients, around 30 to 40%, and 80% of ICU patients have delirium. It is harmful. It increases the length of stay in a hospital. It increases the cost of the caregiver. It increases the burden of caregivers. It also increases the possibility of death. It hurts relationships. It interferes with meaningful interactions and communication. It is always there. It conflicts with patient goals. 70%, more than 70% of seriously ill patients, they want to have cognitive awareness, and 89% patients refuse treatment that impair cognition. So that is where there is a conflict between the goal setting for patient care. And unlike pain, delirium can be seen. It creates a same sense of fear and helplessness, and that causes a lot of caregiver distress. So what generally causes delirium? I've tried to make a small mnemonic out of the whole word. So you can say, drugs like opioids, chemotherapy, dehydration. Then for emotions, encephalopathy, environmental changes, low oxygen, low hearing, low pain. Then I for infection, intracerebral events, metastasis, retention of urine or stool, Again, eye for intake changes like malnutrition, dehydration also, and then immobility. A patient who's a long term in the bed, then uremia, undertreated pain, metabolic disturbances like hyponatremia, hypocalcemia. All these causes add on to delirium. So coming to medications, medications are an important source of causing delirium, especially the culprits are opioids and corticosteroids, and of course, benzodiazepines, and then anticholinergics, diuretics, tricyclics, lithium ions, H2 blockers, and therapies, metoclopramide, alcohol or drug use, or even alcohol or drug withdrawal. So these are the medications that are culprits for causing delirium. Predisposing factors are mainly old age. Males are more prone to develop delirium. Hypoxia, as I said, low oxygen, dehydration, cachexia, opioid use, anticholinergic burden, and a bad ECOG performance status. So these are predisposing factors, and we generally come across these factors in our cancer patients also. Precipitating factors are generally the change of an environment, a patient being inside the hospital in the same bed, in the same room, in the same environment for a long period of time, even at home, if the surroundings are not changed for him, if there is not enough sunlight, if there is no, change in the day and the night time, always the curtains being drawn in, and some kind of unfamiliar stimuli, for example, a kind of a wide or loud noise, or somewhere outside, some kind of a disturbing noise, a construction perhaps. All these things these are unfamiliar stimuli for the patient. Too hot and too cold. These are also precipitating factors. A wet bed, a patient on a diaper has not been changed, or a leaking urinary catheter. There are creases in the sheets have not been changed, a dirty environment. All these things are precipitating factors. So coming to the assessment of delirium, which is an important part, we have to assess because we need to come to a diagnosis of what the exact diagnosis of the patient is, what kind of comorbidities the patient has. We need to find out the onset of change in the mental status, because there can be a recent change in the mental status, in the kind of withdrawn nature or kind of behavior of the patient being changed. Need to see the oral intake, the urine output, the bowel movement, constipation. A long-term constipation generally leads to delirium. It's a very bad, stimuli, an unfamiliar stimuli for patients to develop delirium. A recent medication history. The patient has had opioids, started on opioids, and that kind of a history will actually lead us to assessing delirium also. We need to review all the symptoms. Generally look for fever, any kind of nausea or vomiting, presence of pain, dyspnea, cough, edema, and also the cubital ulcer. We generally overlook sometimes, patients are developing that sores, but then there's nobody to look at it, especially occurs in the ICU a lot. Alcohol or drug abuse, history of fall, a patient with Parkinsonism or dementia or any other long-standing disease. Elderly patients generally are prone to fall, and then emotional and spiritual distress. So, what are the tools that can help us assess delirium? Number one is We all know about mini mental status examination and the memorial delirium assessment scale. There are two more that I'm going to take you through, but these two are the most important ones. As you can see, this is the mini mental state examination, or the MMSE scale that we use. There are, on the left-hand side, you can see there's a maximum score being given for the questions that are being asked to the patient. If the patient is not able to answer, then we have something else called the consciousness assessment method that I'm going to come. So the maximum score given for the time is what is the year, season, and date, or day of the week, of the month, or the month. You give a score of 5. Then the second question, where are we now, or the location, asking the state, the country, town or city, the hospital, even the floor or the room number also. If the patient is able to say that, give him a maximum score of 5. Then 3 unrelated objects, like clearly and slowly, and ask the patient to name all of them. You show him kind of a ball, a watch, a pen, a paper, and then, ask him what they are and what are they used for. You can actually go on doing that, and that will give you a score of 3. So these, I'm not going into much details, but you can actually go through this. I'm sure at one point in time you may have done an MSE, and it gives you a score of maximum score of 30. So the interpretation here, yeah. And the second one is the memorial delirium assessment scale. It rates the severity of delirium. So this is an important scale. It is extremely validated in palliative care. We generally use the MDAS to use it in palliative care. It is 10 item and 4-point clinician rated scale. So you do it yourself as a clinician, and it gives you the awareness, orientation, memory, digit span, attention, organization, the perception, the delusion, the psychomotor activity, and sleep-wake cycle. So cutoff is 13 for diagnosis of delirium. So the patient has to score, at least a point of 13, for to be eligible for delirium. 71% sensitivity, but it has a specificity of 94%. So this particular tool, this particular scale is extremely relevant for us. So as you can see, these are the items, reduced level of consciousness or awareness. Secondly, it is disorientation. The short-term memory impairment is number 3. The impaired digit span is number 4. And reduced ability to maintain and shift attention is item 5. So this is the interpretation. So if the patient scores 0, if he is continuously fully aware of the environment and he interacts appropriately. If it is 1, that means he has mind delirium. He is unaware of some elements in the environment or not continuously interacting appropriately with the interviewer, and becomes fully aware and appropriately interactive when prodded strongly. Interview is prolonged but not seriously disruptive. Similarly, 2 points would be a moderate one, and he is unaware of some or all the elements in the environment, or not spontaneously interacting with the interviewer. He incompletely becomes aware and inappropriately interactive when probed strongly. Interview is prolonged but not seriously disruptive. Last is the severe one, where the patient is unaware of all the elements in the environment with no spontaneous interaction or awareness of the interviewer, so that the interview is difficult to impossible to conduct, even with maximum probing. So, uh, there are two other tools that can be used, and one is called the confusion assessment method or the CAM method. 94 to 100% sensitive and 90 to 95% specific. 10 to 15 minutes of interview by a trained interviewer, where you can actually ask your nurse or the counselor to conduct this test. And there's another one called the single question in delirium. So the single question is, do you think the patient or has been more confused lately? So it is 80% sensitive and 71% specific in oncology patients. That is what the evidence says. This is the CAM algorithm. There are certain features which I'm not going into much detail. You can actually go through it after the presentation is shared. Fortunately, delirium is best managed by preventing it to occur. That is where the management skill lies. So there are a certain protocol that we need to follow while preventing delirium. We need to look after the orientation of the patient. You'll have to, continuously communicate with the patient regarding his time, place, person, trying to stimulate his ideas about where he is, what he is going through. Talk to the patient always. Try to change his position in the room, or if he's being hospitalized or even at home. Mobilization is one of the most important factors, even in a wheelchair. Doing some bit of exercises all the time, some kind of range of motion exercises, or trying to do some kind of very light physiotherapy if the patient is bedridden or patient is unable to move, and trying to shift the bed to a brighter place where he's able to look at the sun or the sky, or there are trees around. Trying to take the patient outside of sometimes I advise my patients to go for even for a car ride if possible. Sleep is an important part here, because we generally don't want to put the patient on medications to induce sleep. So that is where you will need to reinforce the fact that this is the time to sleep. Night time is the best time to get your sleep. So you have to create that that restful nighttime environment for the patient, and then take care of what he sees, what he hears. What are his perceptions about what he's seeing? Is he actually seeing something dark in the wall, which seems like a person coming and trying to kill him? Or is it a kind of a beautiful picture? Or is it really a blank wall? So you need to find out those things. And of course, a kind of what kind of things he hears. Is it nothing that he hears? always somewhere somebody's crying, or somebody is trying to talk about him. All these things are important. And then try to feed him with something which he likes, and of course, that is based on the goals of care. So this is the prevention protocol for delirium. If you try to follow it, I'm sure you'll be able to prevent the delirium even from coming out, happening to the patient. But what happens once it happens? The first step in management is recognizing and naming it. That yes, it is delirium. Recognizing that the delirium has started, and then trying to name it, whether it is hyperactive or hyperactive, or the mixed type. And 50% of delirium can hence be reversed if you recognize and name it. Unfortunately, it remains underdiagnosed, and there are two important studies that say that it remains underdiagnosed. So what are the steps? We treat the underlying cause, and it is always correct the correctable. And then, most importantly, the non-pharmacological approach, and then we go on to the pharmacological approach. We need to monitor the care process all throughout the management, address the family about what is happening, tell them that delirium is not madness. We need to address the caregivers for that, and other psychosocial impacts of delirium that might be happening not only to the patient, but also to the family and the caregivers. So, as we've seen in the causes of delirium, you treat the underlying cause accordingly. And most importantly, one thing that generally bothers us is in palliative care is about opioid neurotoxicity. It's an very important cause of precipitation of delirium. We know that morphine is metabolized in the liver into M6G and M3G. Generally, M3G it builds up disproportionately in renal failure and causes something called neuroagitation. There is an increased respiratory rate, there's agitation, there's myoclonus, and sometimes it also leads to seizures. Interestingly, antipsychotics generally worsen neurotoxicity. So we can use benzodiazepines and hello, yeah. So we can use benzodiazepines and phenobarbital. Non-pharmacological approach are the mainstay of treatment when we know that delirium has happened and we will need to reverse it. So physical methods, or the physical approach is always an excellent physical care. Taking care of the patient. If the patient is bedridden, then we need to take care of the body, the oral care, the daily sponging, the bed care, remove all the creases if they are present, change the environment, try to give him fluids, remove all the causes, correct all the correctable cause, and it's a team approach, and of course a multidisciplinary team approach. Coming to the environment, take care of the five senses as we have already discussed. What the patient is hearing, what he is looking at, what are his perceptions, and everything. And then the nursing care generally. Emotional support, review the history. Is there a past trauma of the patient? And then you assign a social worker or a counselor who is there, and that emotional support should not only for the patient, it should also be for the caregiver and the family. Not the least not the luck, but the spiritual support is also very, very important. You acknowledge the faith and the regret that the patient had. Many times, there are patients, even when they are in the delirium, they would actually generally tell you about their regrets in life. I didn't do that, I didn't do this. So acknowledge that particular thing and maybe assign a spiritual worker or a priest for that person. So this whole thing is a non-pharmacological approach to the patient. Reinforce the good things, reinforce the important things that are required to get him out of that particular environment or the unfaithful stimuli that has been trying to cause this particular thing to the patient. Pharmacological approach, we generally use haloperidol. It is the drug of choice. 1.5 milligrams to 3 milligrams orally, etally, and that is where we can actually recognize delirium to be reversible. You can also start using 1 milligram subcutaneous or IV SOS and then etally, and it can be escalated to a maximum of 20 milligrams per day. So this is the pharmacological approach. There are other medications which generally are not preferred, but haloperidol is the drug of choice. So take-home messages, terminal delirium is always a diagnosis of exclusion. It should not be presumed. We need to prevent it, recognize it, reverse it, and treat it. So that's all from my side. Thank you so much.
Thank you, Dr. Sanghamitra, for the session. And I hope it's very clear about the importance of non-pharmacological methods in management of delirium. Like simple things can make a lot of change in managing symptom like delirium, which we have seen multiple times. Like she mentioned all of it, like reorientation and making them understand where they are talking when we talk to them, day and night difference. So all these simple things are really important, along with the medications which might be needed for management of delirium. We'll take up a few questions before we move on. We have time to take questions. I understand there are at least a few people working in ICUs or emergency department. Here you might be seeing a lot of patients with delirium, I'm sure. So anyone wants to ask any question or?
Ma'am, I have a question.
Yes, Dr. Shweta.
Regarding the pharmacological management of delirium, Madam has talked about haloperidol, but often haloperidol alone is not sufficient. So do we need to add more drugs along with haloperidol? And in terminal stages, the non-pharmacological methods are often not satisfactory. Like the patient himself is not in a condition where he can be counseled or some sort of a spiritual person's training helps. All these things are usually not there in the last stages. And even the relatives are in the state of almost giving up. So in that case, can we use other medications also along with haloperidol?
Dr. Sanghamitra. And Dr. Shweta, would you like to mention which medication that you are referring to or commonly used other than haloperidol in your setting, maybe?
Ma'am, mostly we are using midazolam, lorazepam, diazepam, These and for some extreme cases, we have to consult psychiatrists. So sometimes they prescribe antidepressants also. But what I am seeing in my clinical experience is that it helps only to sedate the patient. Actually, it is not making much difference in the orientation.
Yeah, I think we lost Dr. Sanghamitra in between. Is she back, Shukriya? I think she's trying to join back, Dr. Sanghamitra.
But her coverage.
Yeah.
Yes, she's.
Yeah, I think, Dr. Sanghamitra, are you here? Your video is stuck. Can you hear us? We'll just wait for a minute. Otherwise, I can answer that question.
Okay.
Uh, in terminal stages, yes, we may not be able to do a lot of non-pharmacological management, but still they respond really well, or their behavior changes a little bit when they are with familiar people. Like we in our place, even if they are terminally ill, their family will be with the patient. That works really well. We tell them to talk to them about the something which he or she can recognize, which he or she is familiar to. That works. But other than that, reorientation or any other counseling services may not work in terminal agitation. But that works really well for the when the patient shows the initial signs of delirium or hypoactive delirium, etc. And regarding the medications, yes, sometimes we do use benzodiazepines, but the recommendation is to use that benzodiazepines only after you try a good dose of antipsychotic. The recommended drug is haloperidol. So if you think that the patient is not responding to haloperidol, you can go up to 20 milligram a day of haloperidol. But you give 5-10 milligrams, and then also the patient is very agitated, we can add on this benzodiazepine along with haloperidol, but not alone. If your first drug of choice is benzodiazepine, the patient will become more agitated. Actually, it itself can precipitate delirium. So, as a first line drug, benzodiazepine is not the recommended drug for controlling delirium or terminal agitation, but you can give it along with the antipsychotics. And as you said, sorry, is Dr. Sanghamitra back? I can see her messages in the chat. But
Yes,
yeah,
I'm just trying to keep my video off, otherwise
yeah,
I
sure.
won't be able to get the bandwidth.
No problem.
So what I can actually hear, Sridevi,
Yeah.
I think they are asking about palliative sedation. Is it like that?
No, the question was
Hello?
yeah, the question was like the relevance of non-pharmacological management when the patient is terminal. Can we actually use the non-pharmacological management then? And if the patient is not responding to haloperidol, what are the other medications that are commonly used? I think we lost her.
Okay.
Okay, you are there.
Yeah.
Sorry.
So there are drugs like quetiapine, and as Sridevi said, we can use benzodiazepine plus haloperidol, and that actually amounts to something called palliative sedation. So you're basically sedating the patient because of the terminal nature of the disease, because the patient is is not perhaps going to live for another 2 to 3 days. You have prognosticated the patient, and there is something called terminal agitation. And for that to control, after using haloperidol, which is perhaps becoming ineffective, you are adding benzodiazepine and henceforth reinforcing palliative sedation to that patient. So that is a treatment of choice for terminal delirium.
There is a question in the chat about what are the adverse effects to watch out for when using haloperidol and any contraindications. Are you there? Yeah, I think we lost her again. Usually her network is really good, but I think. Dr. Deepak, to your question. Yeah, Dr. Sanghamitra.
Hello?
Yeah. So the next question in the chat was about what are the adverse effects that we should watch out when we prescribe haloperidol, and is there any contraindication? Hello, I think we lost you again. Yeah, Dr. Deepak, your question was about the maximum dose is 20 milligram per day. We give it usually, the usual route in our setting is subcutaneous as continuous subcutaneous infusion, or we use very less of IV medication or otherwise IV as continuous infusion. And very rarely we have to go up to that higher doses, and that usually been used in terminal agitation, as Dr. Sanghamitra was also mentioning. When it is terminal agitation, we may have to use the higher doses of haloperidol plus or minus benzodiazepine. So yeah, it is either through IV or subcutaneous. So the pharmacological management of hypoactive delirium. Yeah, so very important thing is to differentiate, which I find difficult, is to differentiate between the hypoactive delirium and depression. Suddenly the patient starts behaving like he's depressed. That's what we have seen. They don't talk much, they don't respond much, they are not really interested in talking. So it's very difficult to differentiate between depression and delirium, hypoactive delirium. And untreated hypoactive delirium patients show very bad terminal agitation when they have advanced, they progress towards their end. So it's very important to differentiate that. So the questions like the orientation, place, time, and the MDAS, everything becomes important to differentiate that. And the treatment remains the same. We start them on small dose of haloperidol in the beginning, and usually they respond really well with smaller doses itself. And we ask them some specific questions like, do you have bad dreams or hallucinations at night? Do you hear people talking? Do you see people walking around? Sometimes people say, like, even if they are in hypoactive delirium, they see people or animals or creatures around them. So it's very important to ask those simple questions and check the orientation and consciousness. But the management is see. So it's not harmful when we use haloperidol for hyperactive delirium. It's very important to identify and treat hyperactive delirium, because we often miss. when they are agitated, they make a lot of noise and it's kind of very visible. So then we treat them for delirium. But when they are in hypoactive delirium, that's not clearly, I mean, there's a high chance that we may miss that diagnosis. So it's very important to check for hypoactive delirium, and it is very important to treat hypoactive delirium as soon as you diagnose it. Otherwise, they later they are high chances that they end up in terminal agitation and delirium when the disease progresses. And check out for the treatable causes. Very commonly, we see patients with delirium either with urinary retention, infection, constipation. A few months back, we visited a like he was a retired judge. He was having delirium, and his son was a doctor in a medical college. And we started thinking about the correcting the correctables, and then I asked repeatedly about constipation, but the son kept telling me no, he's not constipated, he goes to the toilet many times a day. So that many times a day was a little bit confusing for me, because that's not quite usual. So then I kept asking how many times, is it satisfactory? And the patient was delirious, so he was not responding to questions anyway. So with lot of discussion, the son gave permission to do rectal examination, and he had ballooning rectum, and we gave a high enema. He was severely constipated. So he was going to the toilet every now and then, but coming out without a satisfactory bowel movement. He was just having leaking of or incontinence of this something like a spurious diarrhea. That's why he was going very often. And he improved a lot. His orientation, everything. He started talking. He started eating well. So then that doctor, he kept insisting, how can someone have this much confusion and hallucinations just because of constipation? But that's the thing actually happens. So it's very important to check for the small things, like whether he has a urinary infection or change in medication, change in the atmosphere, shifted to some other home. So many things are there which we need to ask very specifically, because many of the things are reversible. So check for the reversible causes before we jump into the any medication like haloperidol or quetiapine, whichever medications that you are using. We use quetiapine also. If there is an issue with the sleep, with a lot of agitation, then we start with small dose of quetiapine, 12.5 milligram at night, and then we can keep increasing. And the advantage is that we can go to higher doses with quetiapine, and it can induce sleep also. So if they have a severe sleep issues, agitated whole through the night, then we might try quetiapine also. Any other question? And it is very important not to use restraints. We never, not even once, used restraints for patients, and we were able to manage with medications pretty well. And it is very traumatizing for the caregivers to see someone being tied up. That's not something that they want to leave their loved ones with, being tied up and agitated. So it's very important to control the symptom without restraining, and it is quite possible. We have never used restraints ever in our setting. That's we can easily manage with medications. And it is very important to talk to the caregiver, because many a times patients will be very abusive. They completely change. So sometimes they say that he has never spoken a bad word in our lives. He was such a soft spoken person, never scolded me. Even now he is using such a bad word that I never knew that he knew all these words. So they use bad words, which is very traumatic for the caregivers. So it's very important to talk to the caregivers also, that this is a condition called delirium, and what we are doing, why we are doing, what is causing this, everything that we need to talk to the caregivers also. That is very important. People do a lot of crazy things when they are delirious. I sometimes I don't know how that happens, but people who are totally dependent on their caregivers for activities of daily living, when they become delirious, they get out of the bed without any support. They open the door and just walk out through the corridor. They might have been bedridden for weeks with complete support, but they can just do all this stuff when they are in their state of delirium. So it's very important to talk to the caregiver also, because it might be really shocking for them. We have instances of patients with huge wound on the leg. The delirium was due to severe pain. So that's another important point. We need to differentiate whether it is due to pain or whether it is due to the morphine that you are giving for pain. So it is due to inadequate morphine or overdose of morphine. So thorough pain assessment and giving a morphine trial would help, because sometimes when the pain comes down, then they become less delirious. So these are some of the experience that I just wanted to share in dealing with delirium. If there are no other questions, maybe we'll start the presentation. Sri Priya, do you think Dr. Sanghamitra will be able to join?
She's trying, like she had called once again, so
Yeah.
she is trying. No.
Okay. Okay.
Hello.
You are here. Sorry, I'm sorry. I didn't see you.
Yeah,
Otherwise,
no. I just Shri Priya had given me a small tip, and I tried doing that, and I think it worked. So at
Okay.
least I have 3 sticks. I can see that.
Okay. Okay.
I'm really sorry about this.
No.
Yeah. So yes, you were asked any questions that I can be able
I'm
to.
so sorry. I think I spoke a lot because you were not there.
No.
Can we
That's
start
that's so kind of you, Shri Devi. I'm really. My apologies to the whole platform. I'm very sorry about this.
No problem. So we'll move on to the case presentation, and then we'll take up the rest of the case discussion in
Yeah.
discussion
Okay.
before.
Sure.
Dr. Shweta?
Dr. Shweta, you are muted. We can't hear you.
Hello, good evening, everyone. I am an intensivist working at Metro Hospital, Palam Vihar, Gurgaon. Today, I shall be presenting a case which was there in our ICU till few days back, but now the patient has expired, and it was a particular case of terminal delirium. The patient was 55 years aged male and was diagnosed with carcinoma rectum with metastasis, presenting with chronic liver disease and portal hypertension, along with Ma'am, I can't see the other slides.
Oh, we can see the slides.
The presenting complaints were ascites, hemorrhagic ulceration on lips, delirium, and pressure source over sacral region. Regarding the history of illness, the patient had symptoms of carcinoma rectum since 2015. He had undergone radiation in 2016, consequently the surgery in 2017, and subsequently had been on chemotherapy till 2017. Now in 2020, he had a recurrence and was admitted to different hospitals for symptomatic management. All this had led to disturbed mentation and sleep. On examination, he was confused, afebrile, with normal blood pressure, heart rate, and saturation on room airs. Then regarding the relevant investigations, almost all the blood reports were within the acceptable range, with an hemoglobin of 8.1, TLC count normal, platelet count 1 lakh, creatinine 3.45, which was slightly deranged. Then sodium potassium was also within the normal ranges. Other investigations were more or less within the acceptable limits. Now, psychosocial aspects had a great bearing on him because the wife was unemployed and he was the sole caretaker of the family. He had no family support. 2 small kids who were school going at the time of presentation. Then he was aware of his condition, so was depressed and had no desire to live. And finally, he was seen in the delirious state, where for a short span of time, he failed to recognize his wife also. The medications he was on were included antibiotics, tablet alprazolam, multivitamins, and few analgesics. Now, the main concern regarding this patient was his delirium and his financial crisis. So, in summary, he was a 55-year-old man presenting with C. rectum with metastasis along with chronic liver disease and ascites. And lastly, his most troublesome problem was delirium in the last stage. So, regarding the discussion points, we wanted to know specifically the role of palliative care in this. Then, in general, the management of delirium in cancer patients, the issues faced by caretakers, which were huge as in this case. And I also emphasize on how we could take care of the caretakers.
Thank you, Dr. Shweta. Sweetly, can you just go back to the medications slide? Yeah. Thank you, Shweta.
Ma'am, actually, we are in a private setup where there is no concept of palliative care as such.
Yeah.
So anybody who has slightest psychological symptoms is referred to the psychiatrist, and a lot more medications are prescribed. So prior to joining this course, even I did not know that delirium or things like this could be handled in a specific methods. In intensive care, we do not pay heed to such things.
I think even though you don't have palliative care, maybe the symptom management, maybe you have heard a lot about symptom management through these sessions. That might be helpful. Like even if there is no dedicated palliative care unit, you can, I mean, after this course, at least I hope you will be
Yes,
able
ma'am.
to
Prior
manage
to
the
this course,
symptoms.
actually, we are not sensitized that we can do so much for the terminally ill patients also.
Anyone else would want to ask me, comment on the medications, suggest the medications and suggest how to talk to caregivers and what are the
Yes,
problems? Yes.
ma'am. Actually, recently I had an experience. My grandma was 101 years old. She was suffering from delirium, and she used to. It was a mix sort of, because I am attending it now. I can make out. Initially, she used to be very hyperactive. Then, after some time, very somnolent, and she will not get up, as if she doesn't have any iota of strength in her body. She used to be in this cycle. So since I did a course of family medicine, there I had a we read a chapter. There is a chapter on palliative care. So I had little bit of orientation, of course, and I did a course on psychology. So I started little bit of quetiapine without anybody's help. I read about it, and haloperidol. So the time she used to have this, before that we used to check that her diaper, whether she had UTI. Caregiver was totally illiterate. They were totally illiterate, and she was taken care of by a 70 years old one of my uncle. I am in such a far off place, but over telephone only the things used to be taken care of, the diapers, constipation, all these issues, whatever. Then with the quetiapine and haloperidol, she was really managed well till the whenever. And that haloperidol dose we used to repeat. If 1 5 mg is not working, after 2 to 3 hours we used to repeat that thing. So that way, that frequency of cycle, even the severity was taken care of. She really balanced, managed by 50 mg quetiapine, gradually started with 12.5 mg, and then up to 50 mg. And before that, the sodium potassium in a village setup, it is very difficult. But since she was not hypertensive, so we used to give little bit of ORS, just blindly. If there is any hyponatremia, that will be taken care of. Then little bit of fruit juice, just to correct, in case of any electrolyte imbalance. So diet was very mixed type. She was managed at home till her death with these two things, and that was it reduced her suffering a lot. So that was my personal experience with these two medicine.
Thank you, Dr. Krishnapriya, for sharing that. And yes, as you said, that's very effective it's quite a relief for the caregivers also when you are able to control this delirium, especially in a home care setting and especially when someone is terminally ill. Any other suggestions from the other participants? Do you have experience in managing delirium with antipsychotics, or do you just in your system, do you just refer to a psychiatrist for managing delirium? How does that happen in your setting? Like anyone else can answer. I'm not quite sure how do you manage. Here we don't actually, unless it is a very complicated situation, we don't usually depend on the psychiatrist. We start the initial medication, but there are some complicated scenarios which we come across once in a while. Then we ask any psychiatry friends over the phone, or they may come and see the patient, and then they suggest to change this little bit here and there. But otherwise, to initiate these medications, I think we should be able to, because our focus is improvement of symptoms.
Ma'am, for how long can we continue with haloperidol?
So there are
There's
patients.
no limit.
Yeah, so it's for terminally ill patients, definitely their lifespan will be very short, so that won't be long. But there are patients who are on haloperidol for weeks or months. With the doses that we are giving, we have not seen any extrapyramidal side effects for haloperidol. But there are patients who are on haloperidol for some, so either it can be, it might be for delirium, and some patients for, I'm sure you might have heard in nausea, vomiting, haloperidol is one drug that we use to control nausea and vomiting from the central level as a dopamine antagonist. So that also people are in haloperidol for weeks to months maybe. Yeah, we give it for long term, but not for all, but it is quite possible to give it for long term.
But there are hardly in much antipsychotic for the use of the patient who are very aged, and
Yeah.
even for the terminally ill patient. So you have to try that with benzodiazepine group. With haloperidol is the safest one, and this one also, that little bit of antidepressant always help. That reduces the severity. Most of the very severely ill patients are depressed. So adding little bit of antidepressant that will lift their mood, that will really help.
I don't have any experience in combining antidepressant. We do combine benzodiazepine if the patient is too agitated, but only after a baseline dose of haloperidol, not as a first line. That's a very important point that you all have to remember. Benzodiazepines are not the first line drug for managing delirium, although it is a commonly used drug for delirium. It is not the first line drug. You can use haloperidol, and above that, if you want to add on, you can add a benzodiazepine, but not as a first line drug. We don't have any experience in adding antidepressant. I have not read about it much, but what recommended by the textbooks and what the guidelines says to add a benzodiazepine to calm them down, especially in terminal agitation, and maybe in, as Dr. Sanghamitra was mentioning, in a palliative sedation setting, we do add benzodiazepines. Any other suggestions from others? At least for how to take care of the caretakers. As I've mentioned, delirium is a very distressing symptom for the caregivers, and even for the patients. When they are lucid, they remember they did something wrong, and sometimes they can recollect what they have done. Some patients do say that, so that's very traumatizing for them, that they feel very guilty that I behaved in a particular way. So it's very important to ask them or how they feel when they are like they are symptom free, and it is very important to talk to the caregivers and prepare them that this is not out of anger or anything that they are talking about it. This is a symptom which needs to be managed. So that's very important point to talk to the caregivers. And Dr. Shweta, even if there is no palliative care unit, I think symptom management for any one of the doctors in this group, even if you don't have a dedicated palliative care unit in your setting, or an NGO where you're working, symptom management is something like you have access to all these medications. Maybe some people may not have access to opioids, but otherwise haloperidol or the medications that we use for nausea, vomiting, the constipation, respiratory symptoms, most of these medications we do have access to. But I think it's about focusing from the looking for a cure or looking for the disease control to symptom control, and making the patient comfortable is something that we need to change. I think medications are freely available, but when to use, where to use is something that we can change in our practice. Any other questions? Shripriya, did she join back? Sorry, we lost her again.
I think she is okay.
Yeah. And as you asked, like in other than in terminal delirium, when the patients are at home, it is very, very common. They see very often when you start taking history, when you focus on symptoms, they may say, night may I have people coming and talking to me. I can see dogs everywhere. I can see cats walking under my coat. I can't sleep because of their noise. So these are the complaints. And very importantly, when we give morphine, next visit, make sure that you ask whether they have any bad dreams in sleep. That's even if they are not coming out with full-fledged delirium or agitation, they may have bad dreams. It starts with usually with bad dreams. So I ask them, how do you sleep and do you have any bad dreams? They may say, yeah, I see sometimes. So then ask specifically whether it is hallucination or just a dream. So it's very important to ask ask those questions, especially when you start someone on opioids or any other assessment. That those questions are really important, because in a palliative care setting, this is a very, very common symptom, because we know that many parameters keep changing when the disease is progressing, so that they manifest as delirium or confusion. Dr. Shweta, is there any other specific question that you want to ask? Especially talking to caregivers, I'm sure with the communication session, you might be able to make them understand or talk to them what is happening, what is going on, and what are you doing, what are you trying with this particular medication. That put them in a lot of ease. This is medication that we are trying to calm him down. So those explanations matters a lot for caregivers.
Yes, ma'am. Thank you.
And in your ICU setting, I'm sure you won't have any problem in giving continuous infusions, because the patient is not at home anyway. So if the patient is very agitated, you can give continuous infusions of haloperidol, and sometimes we can combine benzodiazepines along with haloperidol if it is not being controlled properly.
Yes, ma'am, but the only issue is that increasing sedation often leads to the need to artificially ventilate the patient also. Because sometimes they become too drowsy, and in that case, sometimes it becomes required that we should intubate, but then it again becomes a problem.
Yeah, I think there again the communication is the key, and setting the goals of care is really important there. What are you going to achieve there? So discussing about the goals of care with the family members is really important. Then both the parties are very clear about what is the goal, what is that they want, what is that you are going to achieve. Both may be in a different place when you start the conversation, but after the conversation, you'll be able to bring, I mean, kind of both together at the same page. And they are clear what you can provide. And in I don't think everyone might end up in severe sedation.
No, ma'am.
Not, but
It is
might.
seen. It is not so common, and many times we counsel the relatives in such a way that we ourselves discourage intubation in such cases, because we teach them that they are not going to come out of the ventilator ever.
Yeah. So that,
sometimes people agree and sometimes they insist कि नहीं जब तक जो भी कुछ हो सके करिए.
Yeah.
So in that case, when sometimes we are forced to do unnecessary interventions also, since we have to work safely for medical legal purposes also. So if the relatives insist, we have to, otherwise we try to counsel them to the best possible extent that they should let go.
I understand. Yeah, but some cases you might, but because of this, in our setting, we talk to them what you're giving, what is your intention. Your intention is not to sedate the patient, but to make the patient comfortable. Patient may be sedated, patient might be drowsy. Some people say, don't give the sedation, it is okay, let him be agitated. That's fine. There are some people who opt for that. But later on, seeing the patient's discomfort, they may end up in telling, okay, you manage with your medication. We are quite okay with that. But as you said, the conversation, like you do, you prepare, you tell the patient and patient's family about futile interventions is also necessary. If there are no other questions, maybe I think we finished early today. Are there any other questions from any other participants or on today's topic? Everyone seems quite off today, silent today than any other days.
Ma'am, I have a question, although it is not relevant to this topic.
Yes,
But I strongly feel that people are very insensitive to palliative care. Like they think it is not needed at all. Whenever I personally talk to people that I want to grow in this direction, it is always very discouraging. That no, you can't cure anybody. So what is the point of going in this line? Why to leave the anesthesia, the OT and the intensive care for a field where you are certain that you cannot cure anyone?
Yeah.
So what can we do to make people more aware?
Yes, we do. We do use a lot of awareness programs wherever we get 2 minutes, 5 minutes, 10 minutes. We ask people, can we talk about palliative care wherever you go? So we do a lot of advocacy works. We go to the radio, we go to the TV channels, we wear T-shirts where palliative care is written. Where palliative care is written, we wear badges, ask me about palliative care, and we do a lot of awareness programs. And the acceptance might be critical among other medical professionals. But yeah, I think it took almost 18 years, 20 years, more than 20 years to change the perception of palliative care in Kerala, and now everyone is applauding that Kerala has a very good palliative care model. It did not happen in 20 days or 20 weeks. It took more than 20-25 years of hard work from so many people. So it will take time, but at least now people know the word palliative care. Maybe in the wrong sense, but at least they are aware, or they know the word palliative care. So yeah, a lot of awareness programs, talk to people. And when in a hospital walk, what works better is when they see one patient getting good symptom relief and the family quite happy, even if the patient has expired, patient has died, but the family feels so thankful to you. Seeing that, I have seen in private hospitals, people take that as colleagues, especially they say, okay, this is what you do. Then gradually they start referring patients to your department. I have worked in a that kind of setting also, where they have seen what palliative care can do, how comfortable they are after giving the medications, after the team came, how comfortable they are managed in the ICU setting. Then back to back, they start referring people to palliative care. So I think awareness is the key. Talking wherever you get a chance, to talk about palliative care, and you keep learning also.
About the elevator pitch, if you put it.
Ma'am, what we can do further? So this, after this course, is there anything that we can learn from Pallium India so that we can move forward and do better, because we don't have any other teacher in this field.
Yeah, we do
So
have a
That's
lot
what
of,
why my next question was.
yeah.
So good that we have 10 more minutes for today. Yes, we do have hand-holding programs where we can continue mentoring smaller group, one-to-one sessions for patient-based discussions. For a smaller group, you will be allotted with a mentor. That is one thing. And once the COVID is over, at some point of time, you can all visit Pallium India and be an observer, or you can have a hands-on training with us, which we used to have for many years, but shut down due to COVID. But the virtual mentoring program will be still on. And we have a team who work in every state of India who will be helping you to set up a palliative care service on your own.
Ma'am,
You
I
have one
really
session
want
on
that.
that. You have one particular session dedicated for that. I think you will be meeting them twice in the course, where you hear about the opioid availability session, and you have a session on organizing palliative care services, where we introduce you to the state facilitation team, where they work in every state of India, and they will be continuing from their side. So ours will be mentoring in terms of the subject. So we are the subject experts. We can mentor you the case discussions, how to go about the medications and stuff. But they will be helping you with the more of administrative or organizing stuff, working with government, etc. So there is a continuity of continued mentoring in all the levels that you are looking for. And there are some institutes in most of the states where you can go and observe what you have learned in these sessions. So for example, if you take Assam, you can, if someone is from Assam, you can get in touch with Dr. Sanghamitra and be with her for another 10 days. So she'll, and we have another institute, many institutes in the same state, where you can go and observe how do they do things actually. Now you have heard, now we have to see how they do things. So that is also possible. So those, we'll give a list of institutes that we are collaborating with in this group. So you can choose after your course. Certification is mandatory, so kindly pass your exams and get the attendance. And after that, you can be in touch with the institutes in your states.
How many exams do we have?
Shripriya, it's 5, right? 5.
Okay, we had 3 so far.
Yes. Dr. Abhishek, how do we manage opioid-induced delirium? Naloxone doesn't have any role in managing delirium. First thing is to titrate the dose. Whether you, so first thing I would check is whether I'm giving overdose. And second thing, suppose your patient was on 10 milligram morphine for 6 months, suddenly developed delirium. So it may not be like, so you need to think why suddenly this happened. So first thing I would think is like whether he's going on for a renal failure, so that there is accumulation, and that's why the sudden precipitation. Or is he having any chance of brain metastasis, because he was quite okay with 6 months. Or the patient might have undergone radiation therapy, the effects might have started, and now he needs lesser dose. So these are the things that we need to think when the patient is coming with sudden onset of delirium. Or you gave morphine for the first time, and after a week you are reviewing and the patient is telling that they have delirium. I'll reduce the dose. If they were on 5 milligram 4th hourly, I might tell them to reduce to 5 milligram 6th hourly. I'll give a 25 to 30% reduction in the normal dose, and I'll write why I reduce the dose to 6th hourly, because it's not a usual dose to give in 6th hourly. So if someone else is seeing the chart, they might think, okay, this person is not giving adequate dose. So I'll write, I'm reducing it to 6 hourly because the patient had delirium, and I'll start him on haloperidol. And after a week, when I review, I'll try to stop haloperidol and see whether the morphine dose we have titrated, now the delirium is under control. Along with that, you have to think whether the patient is constipated because you have started on morphine, whether he's taking the laxatives properly, whether his sodium is okay. If there is a chance of hyponatremia, we have to check. If there is any hypercalcemia, whether he has multiple bone mets. So all these reversible causes we need to check. But along with that, you need to start medication till we get an idea of how this happened. But naloxone doesn't have any role in delirium per se, but other than, it has a role in morphine-induced toxicity of respiratory depression, or you find someone has accidentally taken a lot of morphine and ended up with a reduced respiratory rate and pinpoint pupil, then I might use naloxone. And to be frank, I've never used naloxone in the last 10 years. We have that in stock, but we never had to use. Usually, if there is severe delirium, I tell over the phone, we tell them to skip the next dose of morphine. So he has taken 6 p.m. We tell them, okay, you skip the 10 p.m. dose, and from tomorrow onwards, reduce the dose by 30%, and then observe. So I think if there are no more questions, we'll wind up today's session. We are so sorry that usually Dr. Sanghamitra has very good network connectivity, never encountered a problem. She's with us for many months. we never had a problem. Yeah, so sorry from that it happened today. Sri Priya?
Thank you, ma'am. Thank you so much for everyone for joining today's session. And I believe, I personally feel that the query or the enthusiasm of doctors like Dr. Banerjee and Dr. Shweta were answered today. They were having this doubt for many, maybe 14 sessions till now. So at least we got time to address those. Of course, some other participants have also been getting in touch with us over personal messages regarding this, and we have been trying to answer those queries as far as we could. So, with that note, this is Sripriya along with Dr. Sridevi signing off from today's session. See you in the next session with another faculty. Till then, signing off from the Chief Seconders. Take care, everyone. Stay safe, stay healthy.